Good morning, everyone. Today I'll be presenting a case on a 9-month-old child which complains of a swelling in the. So the mother noticed a swelling in the right inguinal region, which she noticed since 1 month.
Louder, Dr. Vasnara, a little bit more louder. Come close to mic.
Okay, sir. So the patient was apparently all right 1 month back when the mother noticed a swelling in the right inguinal region. It was of a size of a pea in the groin region, which reaches the bottom of the scrotum when the child coughs and also increases to the present size of the lemon. The swelling disappears on lying down. It is not associated with pain, vomiting, abdominal distension, constipation, fever, or any chronic cough. And there is no history of any recent URTI. The past history is not significant. And the birth history, it was a full term normal vaginal hospital delivery. The baby cried immediately after birth and the birth weight was 3 kg.
Vasundhara, at this time, just I want to interrupt you. You are writing down there full term normal vaginal delivery. Why do you want to know whether it is a full term or preterm?
Sir, that will tell us about our further management, and as well as we can rule out the different congenital defects can be there. The possibilities
till what age of the baby can still have all the problems of prematurity? Because this question can be asked for you in the exam also. What is post-conceptual age?
Sir, it is the gestational age plus the birth.
The post-conceptional age is very, very important. It starts from after 2 weeks after the LMP. When the conception occurs, it is called as post-conceptional age. So how many weeks of post-conceptional age the baby can still have all the problems associated with prematurity, especially, post-operative apnea, apneic spells. That is very, very common in premature children, especially for us as anesthesiologists. Till how many weeks you have to be careful?
6.
Till 60 weeks.
60 weeks.
Post-conceptional age of 60 weeks, till 60 weeks, all the problems associated with prematurity can be there. So it starts from the 14th day, that is 2 weeks after the LMP. So that's why, because you said that this child is 9 months old, that means 36 weeks old, isn't it? So suppose if it is born at 30 weeks, 30 plus 36 will be 66, absolutely 66. No problem, even if it was a preterm child. So that's why, because many of you will be just presenting as full-term normal vaginal delivery, but you will not know why you are trying to tell that. Suppose if the child is still younger, maybe 4 months or 5 months, then you would be worried, especially if the child was born as a preterm baby. Okay, right, continue.
So the baby cried immediately after birth. The birth.
And I think you should know the problems of prematurity and the anesthetic implications of that. You should know about it.
Okay. The baby is exclusively breastfed till 6 months of age. The child has breast milk along with weaning food, and the weaning food is fed 3 to 4 times a day. And the child is immunized till date. And developmental history, the child can crawl, recognize the mother, no history of any obvious developmental delay, and the child and the family belongs to a lower middle class family. On general physical examination, the child is conscious.
What is the Kupusomi scale? Can you quickly elaborate on that?
That is on the basis of per capita income, on the education of the head of the family and the income of the family. We have it is divided into, like, the scales are given and then you calculate them. Then on examination, the child is conscious, lying down comfortably, playful, well nourished, posture normal, no dysmorphic features, spine no obvious deformity, and no pallor, icterus, clubbing or cyanosis, no lymphadenopathy or edema, afebrile, and the pulse is 120 beats per minute, right radial artery, normal rate, rhythm and volume. The respiratory rate is 30 beats per minute, abdominal type of breathing, and 96 the BP is 96/50 mmHg.
Oh,
And
Sundara, did you record the blood pressure? Really?
yes, sir.
You routinely record the blood pressure also, take for a small child for pre-anesthetic evaluation?
So if it is available, normally it is like.
No, if you have recorded,
sometimes
it's
the
fine,
cuff,
because what happens is the child starts crying. Because
yes,
once the pressure is elevated, the child starts crying, then you will not be able to examine the child properly. So majority of the times we don't expect the child to have hypertension, isn't it? 7 or 9 months old child, unless there is a strong some history like coarctation of aorta is there, isn't it? Otherwise, usually may not be.
On developmental examination, the child can crawl, sit steadily, and pulls to stand. The fine motor pincer grasp is present. Social smile was achieved at 2 months. The child can recognize the mother since 3 months. Waves bye-bye and stranger anxiety is present. On language, it responds to names and bisyllables. Airway examination, no facial trauma or deformities. Mandible is normal in shape, and oral cavity normal and no loose tooth. On head-to-toe examination, head is normal in shape. Fontanelle anterior open 1.5 into 1.5 centimeter. Posterior is closed. No bulging or depressed fontanelle. Eyes are normal in shape and size with no abnormal movements. Oral cavity is normal. The palm, fingers, palm arteries are normal, and bilateral upper limb peripheral veins are present for cannulation, and they were marked. And thorax is normal, abdomen is normal, spine appears normal grossly, genitalia swelling on cuffing or straining on left side, and feet no external deformity. Local examination on inspection.
You can skip
okay,
local examination. Yes. Okay.
Okay, sir. On palpation, the inspector findings. So this also?
Yeah, you can skip here.
Okay. Okay, sir. On systemic examination, cardiovascular system, S1, S2 normal, normal vesicular breath sounds were heard, and per abdomen was soft and no tenderness, and the spine is grossly normal and no normal sensory stimulation in all the 4 limbs. So we have a 9-month-old child presented with swelling on the left inguinal region, which was not associated with pain and fever, and the swelling reduces on lying down and extends till the base of the scrotum on cuffing and straining. So provisional diagnosis is mostly non-obstructed left inguinal hernia.
For? Posted for?
Herniotomy, sir.
Herniotomy.
So
that you should always, it's not hernia repair, it's always herniotomy. So, okay, one common question, Vasundhara, whenever a child has any congenital problem anywhere in the body, usually you can be asked, or just name all the congenital abnormalities from head to toe that can be there in a child. So when you are examining, so you may require to rule out all these. So can you just name from head to toe?
From head, if we start hydrocephalus, then sir, eyes, we have to rule out congenital cataract coloboma of the iris.
Very good.
Then we have cleft lip or cleft palate. Right. And then sir, in the neck, we have cystic hygroma or any thyroglossal cyst or webbed neck. And then sir, cardiac, we can have congenital.
Do you see anything in the ears?
Ears, yes ma'am,
any external ear abnormalities can be there.
Which can talk about something which might have gone wrong inside. The kidney disease is associated with the external ear.
Yes. Yes, ma'am.
Even Treacher Collins layer abnormalities. Okay, just continue. Somebody has pointed out choanal atresia also. Choanal atresia also is one of the congenital. Yeah, okay. Come down. Yeah, thorax.
Thorax, we can have pectus excavatum, or sir, in the heart we can have congenital heart defects.
Yes, very good.
And then umbilical hernia or any gastroenteritis. Sir, diaphragmatic hernias, congenital diaphragm.
Of course, they are all in neonates. But for in the examination, the examiner expects you to tell all congenital abnormalities from head to toe. So just remember about this particular question. Okay, now everything is fine. This child, doesn't have any developmental delay also. You said that this child's body weight is how much? 11 kg, is it?
Yes, sir. 11 kgs.
Is it normal for this child or it is not normal? How do you know that the body weight is for a 9-month-old? For 9-month-old, how do you calculate?
So the formula is the 1 plus.
So that is age in months plus 9. The whole thing
yes,
divided by 2.
2.
Age in
Yes,
months
plus 9
divided by 2. So this child should be 9 plus 9, 18 divided by 2. It should be about 9 kgs. What is the weight of the child?
Kgs.
Yeah, you see.
11 kgs.
Exactly. So because you said that Kupuswamy scale, poor socioeconomic status is there. So why we ask that is,
nutritional
any
status.
problem. Somebody is asking me to repeat this. Age in months plus 9 divided by 2. This is only up to 1 year. This is up to 1 year. You have this particular formula. So
and also roughly they say, no, sir, double the birth weight by 6 months, 8 months, and triple the.
Usually doubles by 5 months, triples by 1 year, 4 times by 2 years. That is how it is always there. So for a slightly older child, so that is more than 1 year, you can have age into age in years multiplied by 2 plus 5. 2 into age plus 5. That is for an older child. So here months, because the number of months plus 9 divided by 2. So that's a simple formula. Just remember about it. And what is the importance of this weight for you, Vasundhara? Why should you know about the body weight of the child?
So the nutritional status of the child.
Okay, that is fine. Anything for anesthesia purposes?
So anemia, etc.
Anesthesia purposes, I am asking about the weight. During anesthesia,
so weight of the drug, sir, drugs
that is
should
most
be given according to the weight.
Yeah, according to the body weight, you will go. Okay, one is that. And suppose if you are using a supraglottic airway device, is it
then sir, we have to calculate the size of the supraglottic airway. We have to calculate this. Yes, sir.
That is another thing.
And
okay, now
fluids for maintenance also.
Fluid requirement, definitely. And then, circuit, with circuit, isn't it? And whether you can leave the child on spontaneous ventilation or you have to control or assisted ventilation, isn't it? Again, weight becomes very important. And if you are planning for Caudal, again, your many other formulas like Armitage formula, again, body weight is important, isn't it? So there are many applications of body weight, especially in a child. So you should know about weight. Height you have measured? Did you measure the height of the child? Is it required to measure the height or length? You can say in a child who is not able to walk around, you can also say length.
Length also.
Well, why
so it is needed to.
Yeah,
so
needed for
when
what?
When we have to calculate the size of the tube, so we can calculate with the height, and when we have to fix the tube, then we have to calculate the height. So.
Usually, all those things by weight only, isn't it?
Yes, sir.
Fixing the tube and all. What is rule of 7 in a neonate for fixing the tube?
Yes, sir. For patients of pediatric patient of less than 1 year of age, we have to search for 6 for a weight of 500 grams.
You see, 1 kg, 7 centimeters. The depth
7
of
centimeters.
Your endotracheal tube from the right angle of the mouth to the middle of the trachea. 1 kg, 7 centimeters, 2 kg, 8 centimeters, 3 kg, 9 centimeters, 4 kg, 10 centimeters. And afterwards also, up to 1 year, it is maximum of 10 centimeters only. Usually, you don't keep beyond that because, the length of the trachea, what is the length of the trachea in an infant?
So 4 to 5.
Yeah, 5 centimeters. So chances of going endobronchial will become very common, isn't it? So that is why you should know. So height and weight of the children, and especially older children, like, more than 1 year of age, height is very important. Height in centimeters divided by 20 should be the internal diameter of the endotracheal. It's a very easy thing. And, even for Indian, because, majority of the formulas that are made is for Western children. So their growth may be slightly higher than our children. So this is the best thing. You just measure the height of the child or length of the child, divide by 20, you get, suppose the length of the child is 100 centimeters, divide by 25 millimeter internal diameter of the endotracheal tube, you can select. Okay. Now let us move to the investigation. So okay, this child is being posted now. What are the investigations you would like to do for this child?
Sir, hemogram. Hemogram.
Hemogram means what are the things?
So the hemoglobin. So hemoglobin.
Okay, hemoglobin.
On the
okay, hemoglobin. Why not the total count, differential count? Is it required or not required?
Sir, we have ruled out that in history, sir, already no infection.
Yeah, no infection.
We're not.
That is the reason there is no requirement. And suppose when you try to examine the child was not cooperative. So you don't know whether the child has got any heart murmurs or anything. And in the history also.
Echocardiography.
Yeah. So in the history, how do you rule out congenital heart disease?
Sir, we will ask for any recurrent respiratory tract infections.
Okay.
Or any failure to thrive.
Right. Very good.
Sir, history of tachypnea can be there.
Right. Failure to feed also.
Failure to feed also.
Yeah, because if the child is going in for cardiac failure, so it cannot feed itself. And about cyanotic spells, especially if it is a right to left child. So is it very important for us to know whether the child has got a congenital heart disease? Should we rule out before taking up?
Yes, sir. Because that will tell us our plan. Yes, sir. Yeah. Because that will tell us our plan of anesthesia.
So it can even change your plan of anesthesia, isn't it? If the child is also has associated with some congenital heart disease. Okay, so bare minimum investigations are sufficient for this child. So if you think that an echocardiography can be done to rule out, any congenital heart disease, definitely you can use it because totally non-invasive, absolutely fine. Okay, you have done these investigations. The child doesn't have any anemia, only hemoglobin you have done, and a blood grouping you have done. Right, now the child is being posted. So now the previous evening you have gone and then met the mother. What all the instructions you will be given to the mother?
So first we'll tell the NBM to the patient, to the mother. We'll tell her to give for 6 hours for formula milk or any cow milk, and 4 hours for breast milk, and 1 hour for any clear fluid.
Yeah, because recent Indian guidelines is 1 hour for clear fluids. Okay, people have even given.
What is clear fluid? What do you mean by clear fluid?
I'm
can you give tender coconut?
Yeah, no. No, ma'am.
So you should not.
Yeah.
Yes, sir.
No, original definition of clear fluid was, suppose you take in a clear glass, you should be able to read a newspaper kept on the other side. That was the original definition, but now it is not there. Even, black coffee, black tea, all these things can be clear fluids. Only thing is, and even fruit juices, non-pulp containing fruit juices are clear fluids. Now, majority of the times nowadays, clear fluids, complex carbohydrate containing clear fluids are being given so that you can prevent hypoglycemia. And also, it will be more tasty, isn't it? So that's how it is being given. So 1 hour prior, right? You have told the mother to give clear fluids till 1 hour, right? Continue.
Now, sir, we'll tell her about the procedure, sir.
Okay.
About the general anesthesia we'll be giving, and about the caudal block which we will be giving. So the child will be a little bit drowsy when we are shifting the patient to the OT, and when we get him back, that time also he'll be a little bit drowsy, and the limb movements will not be very adequate. So she should not panic at that point of time.
Will you take the mother inside the OT or induction room?
So that depends if our pre-medication is proper, and so we need not to take the mother to the OT.
It all depends on the institution also, isn't it? If your institution, many of the institutions, they are allowing, because the induction room will be separate, so they can allow the parents till the baby is induced. But in your institution, you are not practicing that.
So sometimes we do when the pre-medication is not like proper, and that time we.
Very good. So okay. Now carry on. Any consent you will be taking?
Yes, sir, informed consent we will be taking.
Right.
After that, we will be taking the informed consent.
Right.
And then, sir,
night you would like to sedate the child?
Sir, no, sir. On the night.
You want to sedate the mother?
No, just the counseling will be enough.
Right. Okay. So now you would like to take the child as a first case in the early morning?
Yes, sir. The child has to be taken first case in the OT list, and then, sir, in the
what pre-medicate you will be using?
Sir, we will be using oral midazolam, the dose of 0.5 mg per kg. And
what is the oral bioavailability of midazolam, Vasundhara? What is the bioavailability of oral midazolam? No, because you are giving 10 times the IV dose, isn't it? IV would have given 0.01 to 0.05. Now you said that you will be giving 0.5 milligram per kg body weight. That is almost 10 times the IV. So bioavailability should be normal or reduced, or? It
should be less, sir. That's
it is just about 15 to 20%.
15.
Just 15 to 20%. That is the reason why you have to give almost nearly 10 times the IV or IM dose. Okay. Any other route you are using in your institution?
So here sometimes when the child is not cooperative, we give intranasal as well in the dose of 0.3 mg per kg. We have the spray intranasal.
Okay.
So sometimes we give.
Right.
But
how the child?
Ketamine or intranasal ketamine?
Yes, ma'am. We can give we can give a mixture also, ma'am, like ketamine, midazolam, and atropine, so that all the properties of pre-medication can be there.
Mix it with what?
With honey, ma'am. With honey, we mix it and.
For oral,
ma'am,
ketamine, not for intranasal.
Yes, for orals. For oral, 3 to 5 mg per kg. We'll give ketamine and atropine 40 mics per kg.
Okay.
Mix it.
Now. The baby is, you have given the, midazolam oral. So yes, when you should give, at least how much time you should have before you take the child inside?
Sir, we are giving orally, so it should be minimum 1 hour prior to the induction. Okay, and for good. IM, we have to give like 20 minutes prior, and IV we can give at that time.
Yes, very good. Okay. Now you are inside the OT. Now you have to prepare the OT because it's a special patient, isn't it? It's not a regular adult patient. It's a special patient, pediatric patient. What all the things you will be doing inside the OT before bringing the child inside? Because the child should be with the mother as long as possible. That you should always remember. What all the things you will prepare here?
So, first is OT temperature. We'll keep the OT temperature of 25 to 26 degrees Celsius.
Why any particular rationale for keeping the OT temperature around 25 to 26?
So the neutral temperature of, it should be kept near to the critical temperature actually.
What is critical temperature? Can you define the critical temperature?
Sir, it is the ambient temperature below which an unclothed or unanesthetized individual cannot maintain a normal core body temperature.
Okay.
Below this, hypothermia will set in.
Okay. For this infant, so what is the critical temperature?
22 degrees Celsius.
No, it is. Critical temperature is 25. Neutral temperature, what is neutral temperature?
So it is the ambient temperature that will result in minimum oxygen consumption.
So there won't be any shivering or anything. So that is what is, that is usually about 28 degrees. So it is in between 25 to 28. You can always keep the OT temperature because, maximum amount of temperature loss occurs by radiation. So radiation means, the temperature gradient between the body and then the ambient temperature. So maximum almost 60% of hypothermia that occurs inside the OT is because of the radiation. So this is the very important thing, and you should prevent. Okay, you have kept the OT temperature to 26 degrees centigrade. Then what are the other things you will prepare for?
So we'll keep the IGL of 1.5 size, and then we'll keep the endotracheal tubes as well.
So you're planning for supraglottic airway device.
Yes, sir. Supraglottic spontaneous ventilation with caudal anesthesia. That is my plan of anesthesia.
Okay,
And sir, I'll keep the Jackson-Rees circuit modification of IRS-TPs. And sir, I'll keep the Rendell-Bakel-Sosek masks. And sir, I'll keep the fluid warmers and the forced air warmers also. And
okay, what are the monitors you'll be keeping ready?
Sir, ECG electrodes and
any special ECG electrodes?
So the
normal
size,
ECG electrodes? Yeah, size?
The size is small, sir.
So you have to, you don't usually may not get the pediatric electrode, so you can cut the electrodes, isn't it? All round, make it small size. So okay. Anything else? You want to keep a precordial stent ready?
Yes, sir. Precordial stent will keep.
So what is the difference between regular stethoscope and precordial stethoscope? How it is different from your regular stethoscope, precordial stethoscope? It is flat, isn't it? It is absolutely flat, and it has got a long tubing so that you can sit slightly away, and it is monoaural. Monoaural, that means only you keep it to the one ear and then listen. So you don't have to, regular stethoscope, you have to put it to both the ears. Here, monoaural and long tubing and a flat. No bell will be there. It's a flat, so that easily you can fix it onto the chest, and it's smaller also for pediatrics. So this is very important. So what are the things you can appreciate by a precordial stethoscope?
So the breath sounds can be heard as well as the heart sounds can be heard. So the bilateral air entry also we can.
Heart sounds, the rate is important in a pediatric child?
Yes, sir. Because the cardiac output is rate. So the cardiac output is rate dependent.
So continuously you are monitoring the rate. Then, intensity of the heart sounds also you are monitoring?
Yes, sir.
If there is a muffling of the sounds, what could be the reason?
Sir, any paradoxical embolism?
Myocardial depression, because you'll be using inhalation anesthetic agents. Children are vulnerable for myocardial depression.
Myocardial depression.
That is how.
What heart rate do you accept? You are comfortable with the heart rate. What is critical? Like if it falls less than 60, then it's 60. Almost arrest. So you will have to take care of that. Never allow it to fall less than that. So that's one thing you have to remember.
Okay, what IV fluids?
Sir, a balanced salt solution, most like regular lactate will be using.
Any micro drip set?
Sir, micro drip set with burette.
With burette, very good. So you have kept all these things ready. The child is sedated, but still, not completely knocked off. So you have brought the child inside. Now, how do you plan now? Induction. So when everything is ready, then only you should bring the child inside, because mother's lap is the coziest place. So as long as possible, you should allow the child to be with the mother. Okay, you have brought the child inside. Now, how do you plan your anesthesia and how do you go ahead?
So the plan of induction is inhalational induction by gravity method. Okay. So we'll just, sir, we'll put on oxygen, nitrous, and sevoflurane.
Okay.
And then, sir,
what concentration of sevo?
So we'll keep it at 2% and slowly we'll increase it to till 8%.
No, it will take a long time. That you are not holding the mask over the face, isn't it? You are keeping it slightly away. So can you go for higher concentration?
Yes, sir, we can go for high
So what's the maximum concentration that is put on a sevoflurane vaporizer?
8%, ma'am.
Yeah. So can you put 8 and
can...
on decreasing?
Yes, ma'am. Then we can decrease it.
Why do you go for sevoflurane? Why do you choose sevoflurane? Why not halothane? Why not isoflurane?
First is the odor is like it is sweet smelling, and second, induction is faster, and plus, ma'am, there is no emergence reaction.
It's a very pleasant, sweet smelling.
Pleasant.
So you were talking about gravity method, no? Which
cardiac, is the, yes, sir.
Which is the other method?
Ma'am, gorilla method is also there.
What is that?
Gorilla method. Ma'am, and that we have to pin down the child using all the four limbs, and then we insert the IV cannula.
Yeah. That can be a very bad memory for the child, isn't it?
Child.
Yes, remember that also. It can affect the children in the long run. They can have post-procedure stress, and it can remain in their memory for a long time. So that is not advisable at all. Yeah, go ahead.
Now, what stage of anesthesia you want to? Now, do you want to give muscle relaxant and then place your supraglottic airway device, or you want to place it when the child is breathing spontaneously?
Sir, when the child is breathing spontaneously only.
Okay. So what stage of anesthesia you would like to introduce your iGel?
So phase 3, plane 3 of Goodwin.
Stage 3, plane 3. Now, why stage 3, plane 3? Why?
Sir, at that time, the muscle, the respiration.
What reflexes you want to abolish when you are placing
upper airway reflexes, sir?
No. Which reflex you want to abolish before you place the supraglottic airway device? Otherwise, it can produce laryngospasm. I am giving you a clue.
So,
laryngeal reflexes. So you want to abolish, because laryngeal reflexes are abolished in plane 3 surgical anesthesia, that is stage 3, plane 3. So how do you recognize? Because this is very important question in practicals. You'll be asked, because unless you recognize it, if you try to push it when the child is light, because you are pushing the supraglottic airway device blindly, it can touch the larynx and it can provoke a laryngospasm, and you will have a lot of problems. Even before.
So what do you do if it happens, sir? What do you do if the laryngospasm happens? Okay, you have not taken the baby to a deeper plane, and there is laryngospasm while inserting your. You wanted to put iGel, isn't it? Yeah.
Yes, ma'am.
What will you do?
Ma'am, first of all, we'll switch off sevoflurane. Either we can deepen the plane of anesthesia, then that can also relieve the spasm, or we can give Larsen maneuver, ma'am, by giving a mastoid pressure over the mastoid, between the mastoid and the stellate process, or we can also, ma'am, if any stimulation.
In this case, anyway you are going to induce this child. You are trying to induce. Already you must have taken an IV line, isn't it? You have taken an IV
yes,
line. So what is the best thing to break this laryngospasm? You can
sucks.
Yeah, you can directly anyway, because it is not at the end of the surgery. It is only at the beginning of the surgery. So you can just break the laryngospasm by giving succinyl choline, and then you can manage.
Any IV induction agent that can help you relieve the laryngospasm?
Propofol, I'm looking at propofol also.
Okay.
20 mg.
Do you ever induce the child, this kind of childs, with an intravenous anesthetic agent? Okay, Sevo is not there.
We can use intravenous also.
Yeah, you prefer.
Preferred one is inhalational. We use propofol.
So you can already IV line is there. Already IV line is there. So definitely you can go for that. Okay, now fine. You have introduced your iGel. What size iGel?
1.5.
1.5 you said. Fine.
11
So
kg.
you have, and you are ventilating the child in the beginning. So, or you are allowing the child to breathe spontaneously, you said, isn't it? Okay.
Yes, sir.
Now, what are the things on your gas flows? How much gas flows? What are the things you will be keeping?
Sir, oxygen, 30,
Oxygen, right?
50% and 50% nitrous.
Very
and
good.
sevoflurane.
Sevoflurane, what concentration?
So 2.4 to 3.
So initially you have to keep high because you have to saturate all the tissues and also develop a concentration in the alveoli. Now, okay, everything is you have done. Now you have to go for caudal, you said. So how do you give the caudal for this child?
So are you giving assisted ventilation here for the baby? Or
Yes, ma'am. We will assess the ventilation, ma'am, depending on if the EtCO2 rises more, then we at that time we can assist. Otherwise, we'll keep the patient on spontaneous ventilation.
Okay, now how do you go ahead for your caudal? What position of the child?
Sir, in the lateral position, we'll shift the patient in lateral position, and
Okay.
sir, we'll flex the knees, but we will not flex the neck, sir.
Okay, right.
That can occlude
Right,
the airway.
right.
And then, sir, we'll palpate for the posterior iliac spine, posterior superior iliac spine, and then so we'll feel with the thumb and with the middle finger, and then the index finger will be on the sacral cornu. So, sir, at that, then, sir, with the short beveled 22 gauge needle, will pierce at a 45-degree angle. Will pierce the at that with under all aseptic precautions. And then, sir, while piercing, we'll feel for a pop. That means that we have pierced sacrococcygeal ligament. And then, sir, at that time, we'll decrease the angle or almost parallel to the gluteal fold we can go. And, sir, at that time, when we insert it, sir, then we can we'll feel.
Which needle is ideal, Vasundhara? The hypodermic needle is ideal, or what is which?
Ma'am, we use hypodermic needles, but it should be stellated actually.
But what's the ideal?
Short bevel. Short bevel stellated needles are the ideal needles.
Yeah,
because epidermoid cyst.
Yes,
ma'am.
Can you use US guidance? US guidance.
Pardon, sir?
Ultrasound guidance.
Yes, sir. Yes, sir. Ultrasound guidance, we can when we keep the probe over the sacral region, we can see, sir, the two hypodermic regions, that is the sacral hiatus, and then, sir, in the middle we will have a hypodermic. Sorry.
Hyperechoic.
Sorry, hyperechoic. Sorry, hyperechoic. Region, and in the middle we'll have a hypoechoic region. That is
so you can even use ultrasonography, isn't it? So yes, what volume and what percentage? Which drug?
Yes, ma'am. We generally use the modified Armitage formula. That is, when here we'll be using almost like we want till the formula is like for sacrolumbar we should use 0.5 ml per kg. For T10 we should use 0.75 ml per kg, and for T6 we use 1 ml per kg, and mid-thoracically we can go for 1.25 ml per kg. So in this case we'll go for 1 ml per kg mostly, and the child is 11 kg, so 11 ml of 0.125 bupropion will be used.
Why 0.125? Why not 0.25?
Ma'am, because here not the concentration but the volume of the drug matters. So and in pediatric patients, the nerve sheath is very.
And you just want analgesia, isn't it?
Yeah, ma'am.
You want analgesia, and you do not want any motor blockade. You just want the sensory. So it is a selective blockade that has to happen. So you're using a lower concentration of the drug.
Actually, what will happen is if you use 0.25% post-operative motor blockade, it will produce a lot of anxiety for the parents. Because the child will not be moving the lower limbs, isn't it? So 0.125 is sufficient. And any adjuvant you would like to use?
Sir, we can use fentanyl.
Fentanyl is a short acting, isn't it? There is no use. use of fentanyl, it may be shorter acting than your bupivacaine. It may produce dense analgesia, but not going to prolong the analgesia.
Clonidine?
Chloride also we can add, ma'am, 13.
Morphine?
1 to 2 micro. Pardon, ma'am? Morphine we can add. Yes, ma'am. Morphine, use these things. Yes, morphine, chloride.
Yeah, clonidine is, you can definitely use.
Ideal.
Okay. Okay, you have given the...
Along with Caudal, anything else you want to see, the multimodal analgesia technique for the post-op analgesia and per-op also. So anything else you do in your institution, like paracetamol infusion?
Yes, ma'am. Paracetamol we can give. And
per-op, can you give fentanyl to the patient? IV fentanyl?
So we'll give fentanyl for sure.
So a narcotic and anti-inflammatory analgesic along with blockade, right? That's what we follow in our institute.
Yes, ma'am.
Yeah.
Here also we give fentanyl for analgesia.
Yeah.
Yes.
Okay, now you are maintaining the child. The surgeon, you would like to ask surgeon also to do something before you start surgery? Because you were asking about multimodal analgesia. Can you infiltrate locally also?
Infiltrate at the site of incision.
Isn't it? So further reduces your, depth of anesthesia management, isn't it? So how do you know that your Caudal is effective?
Sir,
No, you want it to be effective, isn't it? No, you don't have ultrasound. You said initially only you started with blind method, landmark method. So you have injected already. Now you have turned the patient child, and now you have allowed the surgeon also probably to start off. So how do you know that your Caudal is effective? There can be any hemodynamic changes. If Caudal is not effective.
Yes, sir. Tachycardia.
Yeah, that is one thing. Can you use your pulse oximeter probe and PI perfusion index to detect?
Yes. Yes, sir.
Isn't it? You can definitely get the perfusion index in the upper limb.
Both.
Or you can have the perfusion index before the block and after the block.
And after the block.
What happens to the perfusion index after the block?
Sir, it will increase, sir.
Yeah, it will increase. So it's a very easy method to know whether your Caudal is effective, because in particularly children, you don't know, isn't it? And that too on the sedated child or anesthetized child you will be using. So PI can be used, perfusion index. Okay.
Can there be arrest after Caudal?
If it goes intrathecally, it can happen.
So you have to be very careful. Aspirate and see, make
short.
sure that there is. So which level does your dura end? Dura and in pediatrics?
It ends S3, ma'am.
Yeah,
S3
so you have to be more careful, isn't it? Yeah.
So how do you, take out the surgery is over? Now, when do you take out your supraglottic airway?
So when the child is awake and breathing spontaneously.
Will you allow the child to take out the supraglottic airway device?
No, sir.
Yeah, you can allow. You just release all the. Actually. Yeah, let it pull it out, no problem, because it is now you have not inflated the cuff also, isn't it? It is a non-cuff, non-inflatable cuff. Yeah. So absolutely fine. The child was fine, and what immediate post-op complications you expect?
Sir, laryngospasm can happen, sir. And
okay,
then,
so already we have discussed that. So that is only complication you can expect, isn't it? Because you have not given any muscle relaxants also. Is there any problem? This is a male child, isn't it?
Sir.
Male child, any problem with succinyl choline for a male child less than 8 years? There is a caution is always there in the, sometimes it is written on the.
Yes, sir, the bradycardia.
Not bradycardia, that is repeat dose. Male child less than 8 years.
Somebody is saying acetospasm.
So this is very important because, many of these children undiagnosed, muscular dystrophy can be there in male children less than 8 years. So if you give succinylcholine, rare chances of rhabdomyolysis, not the masseter spasm, but rhabdomyolysis. Anyway, we have exactly we have taken 45 minutes. So one common chart I saw is how to identify the Priyanka. Can I just answer one of the? Yeah. So one of the common questions that have been 3-4 people have asked, how to identify plane 3 surgical anesthesia. So, normally you will be looking at the reflexes and also the breathing, eyeball, and then the pupillary size. So, in the first stage, what happens is the verbal response is last. In the second stage, eyelash reflexes are last. Second stage. So, in the third stage, you have various planes. In plane 1, the congenital reflex will be last. Plane 2, corneal reflex. Plane 3, laryngeal and pharyngeal reflex. Plane 4, anal and caranal reflexes are last. Okay, plane 1 and 2, you can easily recognize if there is no corneal reflex, conjunctival reflex. Now, what happens to the eyeball? So, initially, immediately after the stage of analgesia, the eyeballs will move up. So, if you open the eyes, you will not be able to see the eyeballs at all. So gradually, as the anesthesia deepens, the eyeball starts rolling down. So plane 3 surgical anesthesia, eyeballs will be in the middle of the orbit and also fixed, centrally fixed eyeball. That is one thing you have to look for. You just open the eyes. If the cornea is exactly in the midline and the eyeballs are not moving, centrally fixed eyeballs, and semi-dilated pupils, because in the stage 2, the pupils will dilate completely because in the stage of delirium. So, and afterwards, as the plane starts increasing, so the pupil also size will start coming down. So in plane 3, mid-dilated pupil. And the third thing, that if the tone of the muscles will be totally lost. You just raise the upper limb and just leave it. It just falls as if there is no tone. And the respiration will be, breathing will be, shallow, rapid shallow breathing. So rapid shallow breathing, loss of muscle tone, centrally fixed, semi-dilated pupil will be the signs for knowing that whether the child is in plane 3 surgical anesthesia. So one problem with sevoflurane, you think that the child is in plane 3 and you try to introduce your supraglottic airway device or anything, because sevoflurane has got a short blood gas solubility coefficient of just 0.63. So by the time you are introducing, already child may be recovering. So it is always, you can definitely prevent this by giving a small dose of succinylcholine you can give, or even propofol you can give additional, instead of going only for inhalational, because propofol upturns the airway reflexes better than any other IV anesthetic agent. So you can give 1 milligram per kg body weight of propofol. Child may not require 2 to 3 milligrams because already you have induced the child with inhalation anesthetic agent. Just 1 milligram per kg body weight of propofol, and then you can insert your supraglottic airway device. Absolutely fine. You can definitely prevent all the problems associated with this. Okay. Thank you. I don't know whether any other thing is there. So somebody has asked about investigations. Can I answer this? Investigations. So because usually a child does not require much investigations. If the child is ASA class 1, you have not found any problems during history or examination. All children require 1 hemoglobin. That is the only thing. And depending on the requirement of surgery, you can do other investigations. Right. Okay. Thank you, Priyanka. Thank you so much. Thank you, madam. Thank you, Vasundhara.
Thank you, Akkamma, madam.
Thank you, sir. Thank you, ma'am.
Thank you, Vasundhara.
I would like to
Thank you,
congratulate
ma'am.
Vasundhara. She answered very well. That's how we could, talk so many things, and then you can ask so many questions, because it all depends on the answering of the student. If she starts answering fast, then we can ask many questions. Very good, Vasundhara.
Thank you, sir. Thank you so much. Thank you, sir.
All the best.
Thank